Welcome to the CTSNet interview with the Giants of Cardiothoracic Surgery. I'm here today with Dr. Shaf Keshavjee at the Toronto General Hospital and the University of Toronto in Canada. Dr. Keshavjee, thank you for joining us.
Thank you. It's a pleasure to be here.
So many people know your accomplishments in thoracic surgery and in lung transplantation. You're the Director of Lung Transplant here in Toronto and are well recognized for your developments in lung preservation fluid and ex vivo lung perfusion. You're also the Vice Chair of Surgery in the Department of Surgery at U of T, and you're the Surgeon-in-Chief at Toronto General Hospital and University Health Network. I wanted to take this opportunity to ask you questions more from the trainee and early career perspective to understand how you've approached your career and what advice you might have. So to start with, can you tell us a little bit about your early influences and what got you into medicine and surgery?
I always had an interest in surgery, and I don't know where it exactly started, but I know for a fact that I went into medical school to become a surgeon. Throughout medical school and internship, I sort of explored other specialties to see what else might be interesting to me, like cardiology and neurology, a few other specialties, and it kept confirming for me that surgery was a specialty that interested me and excited me the most. Which specific specialty was interesting because I started out in the general surgery program, and it was one of the unique opportunities at the University of Toronto program that we have the surgeon scientist program. I had excelled in school and had a curious mind and had done some small research projects, so I think it was sort of an assumption that I was going to go into the surgeon scientist program, but I didn't exactly know which field. And when exploring the different labs with the different PIs that were around and surgeons doing some really neat research, I think it really reflected the opportunities that are at the University of Toronto. Mm-hmm. I mean, you bump into world leaders and people doing innovative things just in your day-to-day life. And so, as a medical student, I had heard about them having done the first successful clinical lung transplant here at Toronto General Hospital, and I thought that was fascinating. Mm-hmm. I didn't even know what thoracic surgery was at the time, and I got assigned to the thoracic surgery service and learned about lung surgery and thoracic surgery. An amazing group of leaders, Dr. Pearson, Dr. Cooper, Patterson, Todd, Ginsberg, Goldberg, a very, very innovative, leading-edge group doing exciting stuff, and sort of opened my eyes to the field of thoracic surgery. And then while I was on the service, they did the first double lung transplant in the world. And I was able to participate in that. So it was certainly an eye-opener to, this wasn't possible, and this team made it possible. Mm-hmm. It also opened my eyes to the fact that even though you made it possible, it was sort of a one-off or a two-off. I mean, the operative mortality there was close to 100%, but at least 50-50 chance of making it. So clearly it wasn't going to be a routine operation just yet. Mm-hmm. And that was the next step of saying, well, there's a lot of work to be done. Lung preservation was very rudimentary, and the details of the operation were still challenging. Mm-hmm. Airway anastomoses were still falling apart, and we didn't really know why. I mean, it turns out we focused all on immunosuppression and wound healing, where the real problem was airway preservation and mm-hmm. blood flow to the airway.
Right.
And so when we learned to preserve the lung better, we actually solved the problem of bronchial anastomosis, mm-hmm. by and large. So it was a great opportunity to be saying, I want to train as a surgeon, and I'm interested in research and innovation and changing practice, and then having an opportunity to work in a field so exciting as lung transplantation with the true pioneers in the field. And my project was to develop a lung preservation solution. That was the problem at the time. So that was my master's thesis work, and that evolved to us bringing it clinically, and where we used to make it here at the hospital, use it clinically, and then got pharmacy to make it, and then we had, it was commercialized. And that's become the standard of care to this day.
Mm-hmm.
So that was an amazing opportunity and demonstration that finding a difficult clinical problem, putting your basic science investigative skills towards solving the problem and changing care and how it can impact patients. Now a lung transplant is a totally routine operation in this hospital, and today we're doing 3 lung transplants, and it's a busy day, but it's not really out of the ordinary. That's amazing, actually.
Yeah. So just talking more about the surgeon scientist program, which you were part of and developed this lung preservation fluid, what was it about the environment? What are the elements that trainees today that are doing research during the residency should focus on to help bring their research to the bedside?
Well, I think one is to identify an area you're interested in. I mean, there's nothing more exciting than understanding the problem, the challenge clinically, and saying, can I figure out a solution for this? And whether it's a basic science solution or an engineering solution or a technical solution, but how to make it better. So I think that's really important. The other thing is to find a mentor who you can work with or identify with, or who's willing to help you. I think that it's a two-way street of you wanting to do something and get that training, but it does take effort on the part of the mentor, and it takes effort on part of the mentee to sort of form that relationship and make it productive. And I think I've been very fortunate to have had mentors like Joel Cooper, like Alec Patterson, Martin McNeely, others who sort of have helped me in different aspects of my development.
And after the surgeon scientist program, you went on to finish your senior residency in general surgery and then trained in thoracic and cardiac surgery. Following that, you went on to do further training with fellowships in Boston and London. How did you make that decision, and what did you gain out of doing those fellowships?
So first of all, when going back out of the lab, back into the clinical stream, again, Martin McNeely, who was the division head at the time, understood the concept of a surgeon scientist and learning a way to manage both careers, as a scientist and as a surgeon. So I kept in touch. Obviously, I was still engaged with the lung transplant program because I had developed the lung preservation solution, and it was a new technique of preserving lungs. I used to go do the lung retrievals and preservation for the lung transplant team. So whatever service I was on, whether it was cardiac at St. Mike's or general surgery, they would let me go because they needed to send someone to do a lung. But that was both my general surgery program director, Bryce Taylor, the thoracic surgery division head, and everybody saying, okay, here's someone who's committed to a career in lung transplant and investigation, who's made a significant change in practice, and so kept engaged in it. So that was a unique opportunity and a unique process where you would think that other programs, if they were just focused on service delivery, might say, well, sorry, you're on general surgery, and you don't have the day off to go pick up lungs somewhere across the country. So I think it was that part of it. And the other important part of it begins to teach you the balance of the fact that if you're doing two different jobs as a surgeon and as a scientist, you have to balance them. You have to continue both of them at the same time, and portion your time, allocate your time accordingly when available. Often clinical trumps everything else quite often if you're,
Right.
you're a clinical surgeon. So you have to learn to work around that. You have to learn around your schedule getting kind of messed up when you're in the transplant business. Actually, I've spent my whole career trying to increase the predictability of transplant, and I think we're getting there.
We're going to talk more about that. So at the time when you finished your training, you were in Toronto with these world leaders in lung transplant. You yourself had developed both research and clinical expertise in lung transplant. And at that time you decided to go for even further training and fellowships.
Yes.
What led you to that decision?
Well, you know, as you know, as a thoracic surgeon, most of your work is oncology and other aspects of thoracic surgery, and lung transplantation, by and large in the past, has been a small part of anyone's actual clinical activity. My other special interest has been in airway surgery, having grown up and trained with Griff Peterson, who again was a pioneer in his own right in the development of airway surgery. At the time where Griff was clearly one of the world leaders or the world leader in tracheal surgery, there was Hermes Grillo, also a leader at the Mass General, and Louis Courreau in Bordeaux, and these were the three gurus of tracheal surgery. And we had at the time a McLaughlin Traveling Fellowship, which is set up at the University of Toronto for faculty that you hire that have a position to come back to have a year to go elsewhere and learn new things to bring back to Toronto, which is a remarkable opportunity. So I decided to go to work with Hermes Grillo for tracheal surgery, and go to England actually to work with Magdi Yacoub to learn heart-lung transplant at Harefield, and to Bordeaux to do some of the advanced cricrotracheal surgery with Louis Courreau, and brought back those skills. So other than lung transplantation, my other big area is lung cancer and tracheal surgery, which hopefully will also cross over in things like tracheal transplantation and airway regenerative medicine. So those sort of finishing type fellowships at the end of your training, when you're already a trained surgeon but you want some highly specialized techniques to bring back, I think is very valuable. And I think that it's something we need to think of for even established surgeons, that when new technologies come up, you've been practicing for 10 or 15 years, and say it's robotic surgery or minimally invasive or some other technique, that we should create those opportunities for surgeons to have intense training periods to become skilled with new technologies. And I think that's going to happen more and more and at a faster rate. So I think it is something we should keep our eye on.
Okay. So then the next stage of your career after this was actually establishing yourself as a surgeon and a scientist. What was that transition like, and what do you think trainees should focus on now to make that transition smooth? Learning to become a surgeon, you know, some people say you really learn when you start on staff, but at the same time trying to develop a research program, getting grants. What was your experience, and what's your advice about that?
Yeah, you know, that's a very difficult time, because as a new clinical surgeon, you want to establish a practice. You want to establish a reputation. You come to the realization that that's actually how you make your living, by operating and doing cases. So it does matter whether you have a practice or not. On the other hand, in this institution, the bar that you're really measured on is your academic productivity. And it is a little paradoxical that that's not exactly how you earn your living. So, you know, again, it's the balance, but it's also the fact that you recognize that this institution values that idea of new knowledge, research, and innovation tremendously, and supports it. So the first thing is your startup package. You can't do anything with nothing to start. It's hard. So you do need to have a package that will at least give you a running start. And then you do have to focus on it, because, you know, grant dollars are hard to come by. It's very competitive, and you're competing with people that do research full-time, and you have another job too. So it does force you to be in the top tier of your field, and I think surgeons who have been successful at it tend to be in that area, and the other part of it is to develop a research program rather than the idea of my lab, right? As you may know, the thoracic surgery lab here at TGH has always been very productive and has always had multiple investigators from the division working in it. When Joel Cooper and Alec were running it, it was maybe up to about 15 or 20 people, which was considered a big lab at the time. And after Joel and Alec and Tom Todd left, the lab was down to 2 people. So it was quite small. And today the lab is 100 people working on thoracic surgery research. Wow. So 100 people work in the Latin or thoracic surgery labs. And that's not me alone, right? So it is building a team, and you know, my partners, Tom Waddell, Ming Ya Lu, Marcelo Sipel, Mark Dipero, Kazu Yasufuku, you know, Gail Darling, they're Jonathan Young now has joined, are all have their own research programs at varying stages of development. But we have a lab machine that's a powerhouse in terms of being able to capture grants, capture individual grants, capture group grants, capture philanthropic dollars, like from the Latner family, the Sprott family, others that have said, you know, you guys look like winners, and we're gonna support winners, and we keep giving them proof points that their money is being very well invested to provide the best in innovation in healthcare in the world here in Canada.
So that provides a good segue into talking about the recent developments in the lab, particularly with EVLP. You have a lot of different ways that you are investigating and applying EVLP in clinical care and in research. What are some of the recent milestones and some of the highlights with EVLP?
So ex vivo lung perfusion, or EVLP, started with the concept of actually for me it started way back because one of my earliest hypotheses and research plans was to genetically modify the lung to work better after transplantation. So the issue is that you know, to take a lung out of one body, transplant it into another is a very unnatural act. But could we pre-prepare that organ to anticipate what's going to happen to it? Could we make it look more like self so the recipient wouldn't reject it? So certainly IL-10 is a key regulatory cytokine in both the innate immune and acquired immune processes that play a big role in lung transplantation. So I said if we could genetically modify the lungs to upregulate IL-10 in the graft, you would essentially have a graft that downregulates the immune system and enhances the chance of success of the organ. So I set up to do that with IL-10 gene therapy using adenoviral vectors. And over a period of about a decade, we showed that with gene therapy we can do that. You can genetically modify the lung in the donor and have it produce IL-10 and work better in the recipient. And then we realized that while you can do that by treating donors, it's just not entirely practical to be, you know, traveling across the country, across the continent with your adenoviral vectors, putting it into the airway and waiting for the lung to get better. So hence, can we do it outside the body? Well, the cornerstone of lung preservation is cooling. Of any organ preservation is hypothermia, is what protects the organ and gives us a safety margin. But when you cool the organ, you cool down to 4 degrees, metabolism slows down to 5% of normal. So even repairing processes slow down to 5% of normal. And any metabolic or molecular manipulation you want to do, like gene therapy, slows down to 5%. So you can't really modify an organ in an ice bucket.
Right.
Hence, normothermic ex vivo perfusion. So when Marcelo came in the lab, his task was like, can we develop a system to keep the lung outside the body for 12 hours without injuring it? And that had never been done before. I mean, Da Vinci had dreamt about it and had drawn pictures. Carell had done it. A lot of investigators over the years. Stig had done in the most recent work in Sweden, short-term ex vivo perfusion just to test the organ. That's not going to get us to regenerative medicine and building super organs. So really our quest was to develop a platform to build super organs. And we realized we hit a home run, and we've done 430 odd patients now, and really have started a new industry in the field that will transform how transplantation is performed. So one is the ability that 80% of donor lungs are not used because we're not sure of the function. So 20% are used, 80% are not used. So can we test those lungs better to evaluate them and use more lungs? We've shown yes, we can do that. Can we repair them? Simple repairs, extravascular water, treating inflammation, treating low-grade infections. We're already doing that. The next step is, can you actually repair organs in even better ways? So we're now looking at sterilizing hepatitis C and using organs from people who are infected with hepatitis C and so on. So, looking at really personalized medicine for the organ. So we've got that technology, and we realized that it's fantastic. It's doubled the number of transplants we can do and are doing in our center. When we tried to expand that to the rest of the world, surgeons would come. Every major lung transplant program team has visited us to learn ex vivo perfusion. They learn it, they figure it out, they go back home. Probably 1 out of 5 succeed in it, 4 out of 5 fail in duplicating our work. And why is that? Well, it's still complicated, in terms of what you have to do. There still is a lot of art to how we do it. So we then looked at various ways to translate this and scale it. One is to develop a service company that will just do it for you. You're a lung transplant surgeon, you just want to do a good lung transplant, save your patient. You don't really care to be sitting there fixing a lung. And that's most lung transplant surgeons are in that space. Just give me a lung that I can safely do a transplant. So we developed the service company concept, and that was a company that we sold to United Therapeutics in the States, and it's called Lung Bioengineering, and we provide lung repair as a service. Mayo Clinic, Cleveland, Pittsburgh, Duke, Maryland, they have a lung that has a problem, send it to us, we repair it, send it back, they transplant it. And we're scaling that up. The other part of it is the complexity of the technique, and we've built a device to simplify it, to automate it, so that you can actually, instead of having one person managing a device to repair a lung, you can have one person managing 10 lungs at a time, right? And scale it up because we've automated the process. And certainly that's spurred a lot of activity in the field. There are 3 or 4 other companies now starting to make devices. I think that the third area that we developed is training. We're training organ perfusion specialists to be able to put lungs on devices, monitor them, assess them, and make the decisions and treat them. And finally, a diagnostics arm is, if you're going to develop personalized medicine for the organ, how do you know what to do with the organ? What's wrong with that particular organ? Most of the molecular diagnostics that have been developed for chronic diseases or cancer, where you get a test result in 12 or 24 hours, which is great and is okay for those kinds of diseases, but 24 hours is not okay for a transplant. So we're developing diagnostic tests to be able to get the answers in minutes, so we can direct the therapy of the lung ex vivo.
Right.
And finally expanding it to other organs. So we're starting to work in kidney, our liver team's doing liver, and our heart teams and others around the world are working on the heart.
Mm-hmm. Okay, so that this provides a good segue into leadership, and we'll talk about administration in a moment. But the work that you have done, not only have you worked in the research and innovation domain, but you have really thought about how are these innovations scalable, and how can we operationalize them, and have been thinking from a leadership perspective, how do we implement this? Where did that perspective come from in you, or how did you develop those skills, and how important are they to the success of these innovations?
Well, I mean, I think that this concept you're alluding to is something that people struggle with around the world, and I feel very fortunate in this institution that we did seem to have the culture and the way to do that, where even though lung transplant had never worked worldwide, even though Joel Cooper had tried it twice here in Toronto and failed, the institution was able to assess his research, assess his capabilities, and say, yes, your research shows that it's reasonable to try again. And as time has gone by and the kind of world we live in, there's always risk in doing new things. And so, we started to think, well, how do we help surgeons to innovate, to bring these great ideas forward that have changed the world, have saved many lives, and do more of that, but do it safely, responsibly, in a way that people will understand and trust, because things can go wrong. It's a high risk area for sure,
Mm-hmm.
And so you want to know that you've done everything possible to get it right. So that was sort of trying to operationalize or crystallize a culture and a behavior
Mm-hmm.
into processes that could be duplicated. And I think
Mhm.
that would be an important aspect to try and iterate clearly so people understand or see a path.
Mm-hmm. Is there something, or what are the characteristics of commercialization when you're looking to scale these interventions? What is the value of commercialization in bringing research to other parts of the world?
Yeah. It's interesting. I think, when I developed LPD, all I ever cared about was changing transplantation and improving the outcomes. And that alone changed that operative mortality from 50% to 1 or 2%. Because of how much safer it made the operation when you have a lung that's properly preserved. But I also learned the reality of, if you want to get something out to the rest of the world, you have to protect the IP, develop it, market it, make it available, go through regulatory so that it's approved.
Mm-hmm.
So even if you do invent something that's fantastic, it won't get to other people across the country, across the world, if you don't commercialize it. So it's something that obviously I got involved in later in my career, partly because I learned it late, and partly I would say because of lack of mentorship or lack of ability on my own part of well, what do you do when you've got a fantastic thing like this,
Mm-hmm.
right?
Mm-hmm.
Even with LPD, I knew it was fantastic because I knew the clinical problem, and I thought, this is amazingly better than what we're doing.
Mm-hmm.
And we implemented it clinically right away.
Mm-hmm.
But when we looked at commercializing it, the companies looking at it at the time weren't interested because it was a small market. Lung
Right.
transplantation was
Right.
only just starting.
Yeah.
So I was, knocking on the wrong doors, really.
Right.
So, that comes to what we're doing now, is trying to set up the pathway better. When a surgeon comes forward with a great idea, how can you help that surgeon to take their idea and get it commercialized?
Mm-hmm. Okay, the next thing I wanted to talk to you about is the administration side of your career.
Mm-hmm.
So you're the surgeon-in-chief at Toronto General Hospital. How did that come about for you, the sort of leadership journey in medical administration?
I think first of all, if you want to implement change or make a difference in the world, you have to be in a position to be able to make a difference. And so whether it's in a small way of leading your own lab or becoming the division head in thoracic surgery, I think that was my first exposure to true leadership and a big responsibility, because this is the most prominent thoracic surgery division in the world. And it was, but there was a period where it significantly dropped and practically disappeared. And that's sort of when I took the helm. But the other part of it was sitting at the table of surgical leaders here as a division head. I sort of realized how decisions are made, how you can influence change, how you can influence the institution, mm-hmm. how you can lead a group of people, not just the surgeons, but your whole program. Mm-hmm. And that is how you create a culture, you create a winning team, and so on. And I find that very exciting. So it's not so much managing, it's not so much administrating, but it's leading, right? Now, they go hand in hand very often. That is okay. But I think you have to keep that balance of not losing what your original goal is or your purpose, and your purpose is to lead and take this institution to greater heights and make a difference, and you're not going to do that if you just manage it. Mm-hmm. You do have to lead it. That part has interested me and inspired me, and I never thought I wanted to be surgeon-in-chief. But as I got matured as head of the division of thoracic surgery, as head of the lung transplant program, I realized that surgery did need somebody to understand the balance between research and clinical care and innovation, to make sure that our resources were put in the right place, to make sure that the business of surgery is set up to accommodate academic surgeons who have more than just surgery to do in their life. Mm-hmm. And I think being an active clinical surgeon, an active researcher in this position helps me to understand what needs to be done and what kind of environment to create, and I think I hope it's making a difference, that people can feel to be able to do that sort of work.
Mm-hmm. So just from the things we've talked about so far, we can see you're wearing many hats. What are some of your habits or work protocols that help you to achieve all of these things?
Yeah, I think probably one of the most important thing is time management. Probably stress management too. And technology. Like, I've always been an early adopter of technology, so that I use it to help me in terms of connectivity, the ability to do things when I'm traveling. If I happen to be at my country home, that I can get into all my files, at the office. I mean, I had that capability long before Dropbox existed. Mm-hmm. But it was clunky, how to get in, and that sort of thing. But I just know that I may want to do some work on a Sunday morning early, and then wouldn't have the files with me. That was just not practical. So figuring out solutions like that, just so that I can live a life but also be productive, mm-hmm. makes the work not seem like work, mm-hmm. right? Which I think is important. And also prioritizing what you're going to do. There's a million things to do. There's a million things in your inbox, but you've just got to make a short list of what you need to get done today, mm-hmm. what you need to get done this week, what you need to get done this month. That just has to be done. Part of it is sort of being strong. I mean, I work very hard, and I think it's not a normal amount of work, but it's fun. I think that's the key. I enjoy it all. If I didn't enjoy it, I don't think I could do that. And that is truly the gift, to be doing something, mm-hmm. that you truly think is fun. I mean, like just today we were talking, I got to do this talk, and then we've got 3 transplants going on, and one of them's overlapping, and the one I'm going to do is going to be lobar transplants. So I needed my partner to come and help me with the back table while I'm doing the implant. There's a lot of stuff going on, but on the other hand, you think like, well, how cool is that to do on a Thursday afternoon, right? So it doesn't feel like work when you have that kind of a set of things on your plate.
So with all of this that we've talked about, what is it that makes Toronto special to work in or train in right now?
Well, I mean, there are a number of things. I mean, one thing about Toronto is it's in Canada, and it's a great place to live in a great country, and it's looking greater and greater every day. So, I mean, it's a wonderful city to live in, as big cities go, and a fun place to live. But the University Health Network and the University of Toronto have a lot of great people, very collaborative attitude. I mean, there is some competition, but by and large, it's very collaborative. So it's very easy to knock on people's door and say, trying to figure out this technique or whatever. I want to start this program, or how about we do this together? There are a lot of collaborative people. I think our Department of Surgery is one of the biggest, is probably the biggest in the country, but one of the biggest in the world. The surgical scientist program is unique in terms of that opportunity. So we attract very, very bright students that are enthusiastic and want to do stuff, and that's very stimulating. When you just, some days you feel kind of tired and wondering where the hell the world's going, and you see these people and you think, oh my God, the future's bright. We've got a lot of great talent coming through. So those kinds of things make Toronto a great place to work.
I want to close by asking, what's next for you personally in terms of your career, your research, and other aspects of your life?
In terms of my career, I'm still an active surgeon. I do some unique cases in oncology and transplant, and I still really enjoy surgery, so I'm still doing that. The research program, believe it or not, I'm the busiest in my research than I've ever been. What's very exciting about the research, I talked about the gene therapy, that 10 or 12 years worth of preclinical work is really coming down to the opportunity in the next year to do a first-in-man again of gene-modified lungs, and I'm quite excited about that. We're looking at stem cell repair of lungs. We're looking at CRISPR gene editing of whole organs. That's an even more exciting area that we're just starting out in. So the research stuff is still going on really well. In terms of surgery, I think we do need to continue to create a facilitative environment for academic surgeons, and I'm working to create those kind of pathways, but also recognizing that surgery is changing. A lot more of what we're doing is done in an ambulatory setting, and is better done that way in terms of the patient experience, in terms of efficiencies of cost and so on. So we do 25,000 operations a year in this hospital. Half of those could be done in an ambulatory setting.
Right.
So I would like to see building an ambulatory building for surgery, move those small operations that could be done with a better patient experience and more efficiency out of the big ORs, and make room in our big ORs for more of the type of unique operations we do that no one else can do.
Right.
So that is a pretty tall order in terms of transformation of the practice of surgery, and to do that in an academic setting where there's also the business aspects of volume delivery and market share to consider. So that's sort of an exciting leadership challenge.
Right. Well, Dr. Keshavjee, thank you so much for being here with us, and it's been great to talk to you.
Thank you. It's my pleasure. Thanks.